welcome everyone. So welcome to the Patient First Summit. So the name says it all, patient first. Because that's the idea or the target of everything we do and everything we want to do is to put the patient first. And in the end, putting the patient first starts by empowering you as surgeons to deliver the right solutions to the patients, because we cannot deliver anything to the patients without you as surgeons. So as we know today, refractive surgery only addresses about 5% of the addressable population. And so I think together we can have a big impact. And what if we move this, think about the impact we could have if we move this to more than 50%. I think that's where we need to get to. And together, industry and surgeons. And we think there are two major things we need to get to the more than 50%. First one is great results for better vision. Constantly deliver great results to the patient. And the second one is a platform versatile enough to be able to address all the challenges you see in your practice and with your patient. And that's where the patient wheel comes in. This little thing here, which you can also see on the screen. So basically, in the outer layer or the outer ring, you can basically see all the benefits which matter most, or the things you want to solve with your patients. So ease of use for you, treating myopia, treating hyperopia, presbyopia, and so forth, keratoconic topics. So all the needs your patients have. In the second ring, you basically see the solutions, the applications we provide as a company for you that you can use to deliver and address those challenges with your patients. And in the inner ring is basically the core technologies Schwind provides to address those needs. So basically, at Schwind, we are convinced about the versatility of the platform. And we do think with the core technology, we have a solution which you can offer to almost every patient and almost every challenge you see in your patients. There's a very broad versatility of solutions which you can deliver to your patients. So thank you very much. Thanks everybody for being here. Thanks for your patience. Thank you very much.
I was really starting to struggle with my glasses. So every time, I had small things like looking at my watch or looking at my phone. At the beginning, it was really, really funny. But then my patients have started noticing me, I could write with big alphabets, and then I took out my phone. My font size is big and large and everything. And the patients actually started making fun of me, oh, doctor, your font, look at the phone. Oh, you're struggling with this. You need glasses for this. So all my patients slowly started realizing that I'm wearing glasses and I'm suggesting surgery for all my patients. So I used to tell them, no, I had LASIK before, but now I'm struggling with ear vision. But still, you shouldn't be having to wear glasses at all and I've done PresbyMAX treatment to so many patients, to my sister, to my brother-in-law. My mother was in the line, but she had cataract. And so many of them. I went on and on. So it took me about half an hour to decide, okay, I'm going to do surgery now, and it's going to be PresbyMAX. But then, you always have friends. Are you sure you want to do PresbyMAX? Do you want to do something else? The other lasers that you want to do? Are you going to be okay? What if you get keratitis? What if you are not happy with? What if your vision doesn't blend or anything like that? And it scared me back a little bit again. It took me another half an hour to again say, oh, no. I'm going to do surgery, So as surgeons, we're always thinking, even for our patients, we think like that. And then I said, okay, I'm going to do PresbyMAX. And I started talking to a few of my friends. And David Kang in Korea, he said, if there's anybody who's going to touch your eye, it's going to be me. Otherwise, Kishore, I'm not going to talk to you anymore. That's it. That's the end of our friendship. And I said, okay. Then I went to David, did my scans. But then David, as one surgeon doing surgery on the other, he starts panicking, like, hey, Kishore, come on, have a look at it. I said, David, you're my surgeon. I don't want to look at anything. Yeah, and then I didn't look at anything, what he was saying or what he was deciding on, how much of intended. I had monocular surgery because I was absolutely okay with my distant vision in the right eye. I had PresbyMAX. And in 2 days I flew back from Korea, and 5 days I was operating, but I had to adjust my microscope. And I was back in about a week. I was swimming, I was doing my sports, I was more confident with all my work. And I was really, really confident with my patient, sometimes I don't need my reading glasses anymore. So that way I was so much more confident. And my near vision is my fonts, everything gone down. I can see my watch, I can do everything. And then my surgery, I just have to adjust my microscope to about a little bit of minus 1.5. And in 5 days, I was operating on my patients again. So this is the biggest concern, but all our surgeons, when do we start doing surgery again? After PresbyMAX. So for me, it was 5 days. And there's always a myth and concepts, surgeons, we go from booth to booth, and somebody tells you this, somebody tells you that. And I think the biggest fear with PresbyMAX, some surgeon tells you, oh no, you should not have PresbyMAX. You'll have multifocal cornea, and your cornea is going to be like an intraocular lens with so many rings on it. There's nothing like that. I don't know if my scan can come up here. It's an amazing, amazing thing. And I absolutely love what I've had. It was a perfect decision that I took. And I recommend to all our surgeons after 40, 45, whoever's struggling with presbyopia, I think you should come to Nepal and zap you off.
Talking about my presbyopia,
yes,
we are the same year of birth, Dr. Kishore.
Yeah.
So this was a very powerful endorsement by you, putting all your trust in the technology that you use for your patients every day, and now even on yourself. So thank you for sharing your experience. I wonder if we can all fly to Korea to see. We don't have to do this. I think this is
in 3 to 5 years, he's going to be my surgeon.
Okay. That is a good deal.
So we're deciding on breakfast tomorrow.
Fantastic. So thank you, Dr. Kishore. The PresbyMAX is available on the Schwind Amaris laser. Yeah. And it's a module that you can release when you require it. And just now, this experience was truly a personal experience. Thank you for sharing, Dr. Kishore. Thank you. Dr. Bassam, I would like to ask you a question. You have had excellent success with the monocular PresbyMAX approach. Now, how does this technique meet the needs of patients who might be more hesitant or looking for a tailored solution?
Yeah, you guys can all hear me? Yeah. I love the monocular PresbyMAX approach. I think it fulfills certain functions. The first is you're guaranteed of having the perfect distance visual acuity outcome that you would get from any laser vision correction procedure, because you're doing an aberration-free treatment in the dominant eye, and you have all of the accuracy and predictability associated with that. So that means that straight off the bat for these patients, you pretty much guarantee that their distance vision is going to be fantastic. When it comes to doing the PresbyMAX monocular approach, where you're driving PresbyMAX into the non-dominant eye, it has many advantages over the alternatives. So the alternatives, in no particular order, are just with monovision is that you don't have necessarily very good intermediate vision, especially for someone that has a big ad. So if someone has an ad requirement of, plus 150, plus 175, plus 2 or more, if you are doing pure monovision, then at the 75 centimeters or 60 centimeter range, they often can't see, and that's where their computer screen is. So you might measure them in clinic and it's oh great, they're 20/16 and they're N4, job done. But that's not what patients care about. We care about that, that's what we measure. But what they care about is, can I sit on my computer screen? Can I see that clearly? Do I see the dashboard of my car? Can I see my device at arm's length? If you take away intermediate vision, they really don't like it. So, monovision versus PresbyMAX is not a like-for-like comparison on visual acuity. It should be like comparison on and patient satisfaction. And patients want an increased range of focus, right? You might ask, well, if they're 60 and they have a +2 ad, why don't you just do lens replacement surgery on them? Well, a lot of patients don't want to have someone do intraocular surgery on them. They don't want to have a prosthesis. They don't want to have the natural lens of their eye removed and replaced. So there is a patient demand for a, let's say, less invasive procedure on a kind of trusted platform, which is laser vision correction, to achieve reading vision correction. And, you know, we're living in an increasingly more near world. So they more and more come at younger and younger ages saying, oh, it's driving me mad that I can't now do this and that. You know, everything is done up close now on their devices. You know, what they do on their phone, more even on the phones. So PresbyMAX gives you that opportunity for very good close vision as well. It also gives you a get out of jail card. If they're having problems with night driving, which is a problem with a lot of intraocular lens options, with PresbyMAX, they can just wear glasses when they drive at night, or when it's dark, and the vision's perfect. So I tell them that 1 out of 30 people will want that. If they're doing a long drive up the motorway at night, they can put the glasses on just for driving at night. They don't have any problems, but they don't have a problem of glare, halo, quality of vision issues. It's a great approach that fulfills many functions.
Thank you for sharing your experience.
Yes.
Already tried what David Keck is doing. One side, the dominant eye with the SmartSight, and the non-dominant eye with monocular.
I know he's doing it, but Kishore had LASIK on both eyes. When he was hyperopic. Yeah. No, I haven't tried that. There is an argument for that actually, because he's mentioned and actually this patients that are more likely to have ocular surface disease and ocular surface problems. So, if SmartSight becomes an option with PresbyMAX, something that I definitely would look at. It's at the moment I have some patients where by chance we've done SmartSight on one and LASIK on the other, but I prefer to do the same procedure on both. Otherwise they start comparing, one eye is more dry, one eye isn't. Did I have this? They don't understand the technicalities of what we do so much, but I understand the logic.
Yes. Okay, Dr. Victor, we are changing the topic slightly to the SmartSight NOVA with Centrex. You yourself are pioneering the SmartSight NOVA procedure with Centrex. What's making this a premium choice for patients who expect more?
So let's start maybe from the very beginning. So I'm working with Atos and with SmartSight since around 5 years. I think I had the 3rd laser worldwide. So far I performed around a couple of thousands of treatments. So even from the very beginning, SmartSight was excellent because we had a semi-guided centration. So we knew where to center, but then we applied vacuum, and sometimes whoever uses Atos knows that after applying vacuum, we still can slide a little bit off. But still, it was a big jump from the first generation of lenticle extraction, which was a big jump from LASIK to LED. But now, and 5 years ago till now, we had a quite good centration. It worked very well. But still, this centration was not perfect. So this is even a higher quality for patients. Why it's higher quality? Because we can measure aberrations, we can measure coma. So whenever you have a slight decentration, even through the semi-guided centration, we lose a little bit of quality of vision, and this might be a subjective consequence for the patient. So having this new feature, this increases the quality of vision, decreasing the aberrations, and this increases the premium experience for the patient.
Yes.
So what are patients looking today for? Patients look today for high quality of vision and for a fast visual recovery. And fast visual recovery, what Schwind achieved, it's while introducing asymmetric spacing, which increases the experience of visual rehabilitation, and we are getting today to the same level of femtolasic. So we have a lenticle extraction, we have no flap, we have less dryness, and we have I would say, same experience as a femtolasing. And I think this is challenging with a superb quality of vision. So combining these features, we are entering a new era of lenticle extraction, and not only lenticle extraction. We are not talking anymore about the alternative of LASIK, but about something completely new experience for patients, having less dry eye, seeing the next day, and having really a super premium the treatment, which is called today SmartSight NOVA.
Thank you very much. I think we are entering a phase where lenticle and extraction is not just an alternative to LASIK, but it is a superior choice when done right.
Exactly.
And the SmartSight NOVA of Schwind is making that very clear. Thank you for sharing your experience on the NOVA. Last but not least, Dr. Shadi, we are again going to a different topic. You have been leveraging the Amaris platform for therapeutic treatments. Now, can you elaborate on how technologies like TheraCare of Schwind are enhancing your practice and making the Amaris a true all-rounder?
Yeah, exactly. I mean, TheraCare is the technology where advanced diagnostics tools, smart software and visualization software and planning, and very high-tech laser treatments are all in one. Actually, this is for me what differentiates the Amaris from any laser around. I mean, any laser can do a good job, and I don't think the patient can sometimes really differentiate between a 2015 sharp and 2015 a little bit hazy. We sometimes can until we do contrast, and I think the Amaris does a great job, but sometimes not a lot of surgeons or a lot of people can differentiate it. But what really can differentiate the Amaris, hands down, its ability through TheraCare to leverage all these very advanced diagnostic tools, and more importantly, being able to plan them, visualize them, and treat. For instance, if you have a very irregular cornea, whether it's the epithelium or whether the total corneal power or the posterior curvature, or maybe something in the intraocularly, the diagnostic tools of the Amaris can detect the wildest aberration in an intraocular lens, or the most irregular epithelium, or the most irregular posterior corneal surface, something that is not present in any laser. And more importantly, being able to plan or decide which one you're going to treat, visualize, that's more important through the Foresight, being able to plan and know where we're going. And this is good, let me try something else, this is better, and then ultimately deliver it. Additionally, now we've seen in the new software, we knew a few years ago there was the customized ablation area PTK, where you could decide on a certain area. Now, if you want to check the software now, the newest updates, you have a masked PTK. You can tell the Amaris, treat anything within a certain pachymetry or anything within a certain curvature. Anything more than 48 treated, which means you'll be able to clip a certain area of your irregular shape and not being able to go ahead and ablate the rest of the cornea. So many versatility, and at the same time, so much power to the surgeon to be able to empower the surgeon, give them the ability to look forward, see what might be your final shape and readjust accordingly. I think that hands down is a major asset for the surgeon, but also marketing-wise is great to be able to tell the patient that this the same laser that can do things, that can fix things that other lasers can't.
Yeah. Thank you very much for all these valuable insights to the expert panel. It was great to have you this morning. We were off to an interesting start. We made some noise, this morning. It's clear that meeting patient expectations today requires not only skill, but also the right tools. So I'm proud that Schwind solutions are enabling this excellence across refractive and therapeutic care. Before you have more champagne, thank you again to the expert panel, and thank you all for joining us today.
Thank you.